Welcome, everyone. Thank you for coming to our last Issues in Aging seminar for this academic career. We've had a great run and we're finishing up with just a fantastic program today. Before we get started, I want to make a quick announcement about the Friedman lecture that's coming up on Wednesday. As you can see, we're having Joe Coughlin, the head of MIT Age Lab, come and talk to us about innovations in aging and entrepreneurship. And in this meeting, we also announce our award winners. And today, we are catching up from the fact that our Friedman lecture was canceled last year. And we are focusing our recognition on Joan Denison right now because she was last year's winner of the Friedman Award, which is given to folks that make outstanding contributions in service to older adults in the community through practice, advocacy, and research. We'd like to thank the Friedman family, represented by Lynn Hamilton, who hopefully is on this webinar today, for their contributions making this award possible. So Joan was our award winner in 2020, a well-deserving recipient of this award as president and CEO of Covenant Place, an affordable senior living community in St. Louis County. Joan helped to re-envision the potential for the organization and spearheaded fundraising, planning, and development of 2 residential buildings and the Mirowitz Center, a community hub for area older adults, which features the Washington University Primary Geriatric Care Clinic. It also has physical and occupational therapy, audiology, podiatry services. Joan actively advocates for programs and services to support older adults and has made such a big difference in our community in terms of healthcare. So congratulations, Joan. A bit belated recognition of this wonderful contribution to our community through this award. Thank you very much.
Thank you.
And Joan is going to be participating in the panel today. The panel is going to be moderated by Dr. David Carr. David has worked closely with Joan in opening the primary geriatric care clinic at Covenant Place. He will be moderating the session where he has his outstanding staff here today to tell you about this experience. David is the Alan A. and Edith L. Wolff Professor of Geriatric Medicine at WashU and has lead roles in the Rehab Center and Parc Provence, as well as the Geriatric Clinic at Covenant Place. So with that, David, thank you for moderating this panel, and I'm going to turn it over to you.
Nancy, thank you for the introductions. And before I go on and introduce some of our wonderful providers, staff out at Covenant Place and our geriatric primary care clinic, I just want to say again, kudos to Joan. I've had an incredible opportunity to work with her. I always like to say 3 or 4 years, but I know it's well over 5, probably 6 or 7, and just had a wonderful opportunity to meet her, experience her vision for older adults in the community at Covenant Place and the Mirowitz Center. We're going to bring her back here in just a little bit to talk a little bit about some of the history and how she's been able to bring together just a wide variety of resources and support, which I think is a true national model for older adult care in this country. Our geriatric primary care panel, I'm very pleased to introduce, and in no order of importance, because everybody is certainly a critical part of our team, but Dr. Tim Holden, a geriatrician from WashU faculty member, is one of our primary care providers and really started things going for us several years ago. And really, Tim, appreciate you joining our panel here today. And from the perspectives of your care, we'll look forward to hearing from you a little bit about what makes our clinic unique and why you chose that. Dr. Kaori Sakurai, internist and also a specialist in older adult care who's been in the community many years, is trained at Barnes here and has been working in subacute long-term care, and we just also primary care at BJC for many years. So we're just delighted she's joined our team. Kaori, I think we're coming up on a year this summer, if that's possible, and If I say that, it's probably longer than that, but in any event, appreciate it. Lacretia Daniels, our nurse practitioner, who's been in from the get-go and has had a long time history in providing care at BJ, and just great experience, wonderful interactions with our folks. She's also here with us today, and we'll look forward to hearing from her. Megan Herman, our caseworker. Megan had some ties back in the day with the Alzheimer's Association, and she provides some great, wonderful care to our patients, and especially the adult children and caregivers. And if you think we can do without her, since she was on vacation last week, everybody was, there was weeping and gnashing of teeth in all of our geriatric assessment clinics and primary care offices without Megan around. So we're glad she's back, and we'll look forward to hearing from her. And then Nicole Triefenbach. Nikki is our practice manager, and it's just been amazing that we've had her these several years, and how she's breaking down a lot of the barriers. This is a new experience for us, a new clinic situation, and she has just been an amazing backbone of the clinic to get us through all the issues related to WashU and BJ and COVID and the pandemic, government regulations and logistics, insurance. It's been amazing. And so I know she's got probably 3 other appointments right now, but she'll be popping in and out of the background. And if we get into some questions about logistics we can't answer, we know that we can circle back and from that standpoint. But enough. I hope I'm not missing anybody from an introduction standpoint. I'll pause to see if I've missed anything. All right, I think we're good. I saw a few shake of the heads. So to start things off, I'd like Joan Denison to take the floor here for a few minutes, take the Zoom, and just talk a little bit, Joan, if you would, about your history at Covenant Place, and just the vision that you had in creating this center and the Mirowitz Center and primary care, and how it came to be, because I think it's an interesting story, and it's just been a fascinating one to see how it's unfolded.
Thank you. So just to provide a little background and context, Covenant Place is a nonprofit senior living community. We've been here on the Millstone campus by the J in mid-St. Louis County, for those of you who know the area. We've been here for 50 years, providing primarily HUD-subsidized affordable senior housing. Our nonprofit mission is to help older adults to age well and independently, and we expanded that mission to not only serve our own residents, but to serve the many senior residents who live in this area. This area is actually a naturally occurring retirement community. So after the Afton area, I think we have the most over 65 than any other area in St. Louis County. So very dense senior population. I've been here for 10 years, just had my 10th anniversary. And when I walked in the door, it was obvious that the buildings had really not aged as well as our residents. Pipes were splitting, things were not working very well. And our board determined that it was time to redevelop the property so that we could continue to be here for the next 50 years. And so we started a journey, and that journey included thinking about how we could better serve our residents and the area older adults, and how we could help more people to age well and independently. Because while our buildings weren't faring so well, our residents were doing very well. And out of our 400 residents, about 20% are over 90 to 102 years of age. This is an independent community. So that gives you some idea. When you can bring services where people live, it helps them to remain well and independent longer. So as we started to research how we would do this project and what we could do, since we were building these new buildings, we looked at a lot of models around the country, and we saw models where you might have healthcare with residential community, or you might have programs with residential communities. But what we didn't see, at least we didn't find it ourselves, was something that was very holistic in its approach. So you would have residential building out with the community access, with affordable nutrition, with lots of programs and exercise and things for health and wellness and for cognitive stimulation and opportunities for older adults to meet up with friends and meet new ones, which is important as our social circles diminish as we age. And then to be able to easily access the healthcare services that we see many older adults don't access because of the difficulty to get to a doctor appointment, the confusion of being sent to many different specialists and so forth. So we thought, let's see if we could bring healthcare into this big master plan. And actually, Dr. Carr, I met you. We contacted Washington University with the goal of not only having healthcare, but also, you know, doing some research with it, doing some training with it, so that we could bring up the next generation of doctors and healthcare professionals who understand what a senior adult is, what an older adult is. And we contacted actually Dr. John Morris, who put us in touch with Dr. Carr. And together we put together a survey. And it was a survey about healthcare needs and concerns. And we distributed it to 500 older adults who live here at Covenant Place and in the greater community, just a blind survey. And what was most interesting was that in a survey of this nature, you would expect, I mean, a great response rate would be 5%. We got a 40% response rate to that survey. And what was also interesting was that we just asked the question, if we were to locate healthcare services here in Covenant Place community, would you be interested in using those services? And without even saying who the provider would be, 70% of the respondents said they would. So that gave us a real sense that location and accessibility was very important to people. And then we worked together, and I really have to give Dr. Carr so much credit, because I can't tell you how many appointments we went on together, looking at models, looking for resources to help start this project. And it was quite a journey. And Dr. Carr never wavered, so thank you for being my partner in crime as we explored the opportunities. And then we were very fortunate to receive a very nice grant from the Missouri Foundation for Health about access for care, access to health care, and that helped us to really get launched. So it wasn't fast. So if others are looking to do these types of projects, you know, this planning can take a little time, but it's worth it. It's worth it to make it happen. And we've been thrilled to have the clinic here. It's made a huge difference for our residents. We had one resident who, after meeting with Dr. Holden, was so excited. She reported to us that she actually showed us 2 full-size pages of laminated business cards. There were 16 of them. These were all the doctors she was seeing. And all she was doing was going to doctors, and she was confused, and she had all these medications. And she went to Dr. Holden, and she came away with only 2 cards. And Dr. Holden, and this was a life changer for her. And, you know, these kinds of stories we hear all the time about what an incredible difference this quality healthcare has made for the residents and the community seniors who come not only from near, but from far to this wonderful medical team.
So Joan, thank you for that that background. And I have to say that it really helped jumpstart our effort to get some funding from the Missouri Foundation for Health. And they've been incredible in their support. And as we've gone through and built our practice and been able to get things going regarding some of the infrastructure, some of the equipment, salary support, et cetera. And again, when you start something from scratch, you know, it takes a lot of planning, and we probably drove you a little crazy with all the floor plan changes and things like that. And I'll also mention, although this is an aside, that it's worked out very well. For those of you who know, our division of geriatrics is also a division of geriatrics and nutritional science, with Dr. Sam Klein as our division chief. And the space that we're currently in also accommodates the weight management clinic. And Nikki also is in charge or oversights that from a practice manager standpoint. And that's also a nice blend from the standpoint of when you think about, older adults, we often think about anorexia and weight loss, malnutrition, but obesity is also an issue in some older adults. And I think will probably be a growing area that we need to kind of monitor and watch. So having both clinics, I think, really set us up to provide a lot of interesting support and collaboration from that perspective. So, well, let's go ahead and start making the rounds with our panelists, if we could. We'll start off with Dr. Holden. And Tim, if you would, maybe give our audience a little bit of your background training, but then when it sort of came down to it and it was time to make a decision, why you wanted to, I remember specifically what you said, but I want to hear from your perspective what attracted you to the position.
Sounds good. So hello, everyone. I'm Tim Holden. So I did my internal medicine training in Wisconsin, and I ended up doing a geriatrics and palliative medicine fellowship there. And I extended my training. I always joke because I married a surgeon, and so I had to somehow stretch my training to match a surgeon, which is never fully recommended. But so Sarah, my wife, came down to WashU for a fellowship, and we fell in love with WashU in St. Louis. We have young kids, very family friendly. But then I finally realized I had to get a job, which was sort of a shock to me, because I'd just been playing the academic game way too long. And so I also was sort of connected with Dr. Carr. I think all sort of spokes lead to Dr. Carr at WashU when you're interested in older adults. And I heard about this clinic and got really excited. I actually did not think I was going to do primary care. This was not quite on my radar, but I had some early meetings with Dr. Carr and Joan, and I sort of fell in love with this idea of this vision they had and what they were building. And I would say I have great timing because they had already done so much of the nitty gritty legwork to get it going. And I just sort of sailed in as the clinic was about to open, which was nice. So what attracted me to the clinic? I think Joan said it extremely well. Finding the gaps in sort of the overall sort of holistic care of older adults. I sort of think of it, and I use this with patients too to explain it, I sort of think of it as sort of this wheel of their well-being in healthcare. And there's spokes, and the more spokes you have sort of supporting the wheel, the more solid and the wheel is. And I think of the physician as one spoke, and it's no less or more important than I think all the other spokes. And this vision that was sort of being created involved bringing all those people together, all these spokes together to sort of support older adults. And I loved that. And I saw that so much in my training. We'd see some of these complex medical conditions in these older adults, and they'd, come to the doctor with a 15-minute visit and sort of just say, I need help. And it just was this sort of floodgates open of emotion of how hard things have been and multifactorial, and where do you even start? And this clinic actually is the start and sort of the finish. It's sort of this holistic sort of progression of care. So it speaks to the team. I mean, I think team is so critical. It's not just in healthcare, geriatrics, that's sort of everything. And so joining Joan and Dr. Carr early on as the team, and then we've built an amazing team. And I'm not just saying that because they're all staring at me through Zoom. It really is an excellent sort of team that we've built. And geriatrics is all about team-based care. It really is. And it's not just the team here. We have relationships out in the community, occupational therapists, physical therapists at the Rehab Institute, home health agencies, social workers. Megan's been a great asset in sort of linking me up with a lot of sort of her community resources. And I realized that our team is like hundreds of people. And so sometimes the service we provide in this clinic is plugging people in with the right team in the community, in the home, transitions of care and things like that. So it's been really fun. Dr. Sakurai has been a huge asset, and we just hope we're going to continue to grow in the future as well. I hope that matches what I said to you, Dr. Carr. I have no idea what I said to you.
It did. It wasn't quite in the paragraphs, but it was pretty much it just seems like a dream position because of if you were going to build a clinic for older adult care, this is what you would want it to look like. That was what I kind of recall, and it's I feel like it's held true. It's just any geriatrician's internist sort of dream to have a clinic, and we allow adequate time to assess our patients, and we've got an incredible team that starts there, and then just to have the Merowitz Center and Joan behind us has been huge. Well, let's move over to Dr. Sakurai, and I think it would be great, Kaori, if you could again tell everybody a little bit about your background, training, some of the practices that you have. You're not quite as long in the tooth as I am, but you've been out there working a little bit, and so I think it'd be great. And then how were we able to pull you into primary care? I think that's an interesting story. Back to primary care. So, yeah.
Exactly. Yeah, so I was born and raised in Pennsylvania, but my connection to St. Louis is that my husband is from St. Louis, and we all know that people that are from St. Louis eventually come back here. So when it came time for training and doing my internship and residency, I really looked at just basically the St. Louis area and was very, very fortunate because the Barnes-Jewish program has such a strong internal medicine program. And I actually focused in on primary care at that point. Loved the program, loved the people that I met, and then went straight into primary care internal medicine at that point. I actually worked out in the community for over a decade, loved seeing my patients there, and really, really enjoyed the community. When my kids got a little bit older, I wanted to kind of step back a little bit and work part-time. And I was able to actually transition into a position in post-acute care. So I was taking care of patients, mostly older patients, mostly our Medicare population, where they needed short-term rehab, where they were coming out of the hospital, but they couldn't quite make it home. So they needed a place so that they could strengthen up and just as a bridge to getting back home. So I was there for about 5 years, loved actually focusing in on our elderly population. But the one thing that I really missed was the primary care component. So I would see patients for 2 weeks, maybe up to 4 to 6 weeks, but then that was it. And since all my life, I've really wanted to do medicine and wanted to do primary care, that was where I felt, well, I needed to kind of look at what other options were available. Again, like Tim said, all roads seem to lead back to Dr. Carr. And in talking to him and talking to Joan, it really seemed like the ideal way to get back into primary care and to focus in on the elderly population by working with WashU primary care, geriatric primary care. And so it's really been just the dream job. I've really been very, very fortunate to work with a wonderful team. I think that it's great because I've had that experience in internal medicine primary care. And like Tim had said, one of the problems is that you do get 10 to 15 minutes with your patients. And with our population, you cannot, that doesn't do justice for our patients. And so with our clinic, we're able to spend more time with the patients, and our team includes also the caregivers. And I really feel that we are able to take care of the patient completely by pulling in the caregivers, the adult caregivers, as well as the patients, and really help to coordinate their care. So I just want to thank you, Dr. Carr, for everything that you've done. And Joan, thank you, because it's just been a wonderful experience.
We're glad you're here.
Thank you.
So I want to thank you again, Kaori, for sharing that information. And I think it's, we love happy providers. We want to keep things that way in clinic, but it's been great having you as part of the team, and really appreciate it. Now we're going to go move over to Miss Daniels, who I love her background. I don't know, I think I read where the largest library is the Library of Congress with 170 items. So I don't know if that's the Library of Congress, Lacretia, or a Harry Potter background that you have there, but it's great. But please, if you would, tell us a little bit again about past training and efforts and why you're here in the primary care clinic at Covenant Place.
I'm zooming in from Italy. Just joking.
Wow. All right.
No, I'm born and raised in St. Louis. As for the age-old question, I went to Parkway West, and then I got my undergrad at Mizzou and my master's at UMSL. A lot of my initial nursing occupation was done in cardiac ICU, emergency room, and urgent care. And then I kind of transitioned over to cardiology specialty as a nurse practitioner. And then I fell into doing hospitalist role in the hospital. And eventually I ran into an advertisement, I think, from Dr. Carr's office saying they needed a geriatric nurse practitioner. It sounded like a good idea. And I came and talked to him, and I talked to Joan, and it seemed like a really fun new model to get into. Most of my patients had been older adults and geriatrics, especially in the roles of cardiology and hospitalists. So I definitely have a good way of getting along with the older adults. And I thought that the model that was presented to me was something that I would be proud to be a part of. And so here I am. You're muted.
Really appreciate your expertise and addition to clinic. And it's great having that ICU stuff. So when the chest pains come in, I'm like, Lacretia, we've got a hot case here we need your help on. So no, it's all good. So we appreciate you being part of the team. Look forward to continued care. We'll move along now in our panel over to Megan Herman, our caseworker. And Megan, perhaps you can not only talk a little bit about your background, but how you serve a lot of roles. But we've talked a lot about geriatric primary care, but Dr. Binder and I also have a geriatric assessment clinic out there, and I know you provide some assistance to both clinics. So perhaps you can also answer the question, when assessment, when primary care, that sort of thing, along with the background. That would be great.
Sure. So I'm a social worker. I have my MSW from the Brown School and have worked in various community settings with older adults my entire career. So I've worked with the Alzheimer's Association and with a couple of local governments providing services and supports for older adults in the community. I had moved away from St. Louis, and as Dr. Sakurai said earlier, we always come back. So I had just moved back and was looking for a new opportunity and saw this listing and knew it wasn't one I could pass up. So I was fortunate enough to be called in to talk to you all about this. And it was such a great model in every role that I've ever had in the community. It never fails that you hear from people how difficult it is when they go to the doctor and they're getting information in those 15-minute sessions, and then they leave and they're so confused about what they heard. They don't know how to follow up. They don't know who to talk to. And so you're trying to connect those dots for them, and being able to be a social worker integrated into the health clinic and be able to provide that follow-up education and support there and then during the appointment or shortly thereafter, and to be that kind of liaison with our patients in between appointments and provide that support and education for both them and their families has been a real great opportunity. And it's something that is very much needed for our patients. So as you said, I work in a couple different roles with our clinic. I support our primary care clinic, mostly just with our three providers. When they have somebody who has some psychosocial needs beyond what they're providing in the clinic appointment, they'll send me a note and I'll follow up with either the patient or the family, provide them with some resources, connect them with people in the community that could be of assistance to them. And a lot of times it's providing education and information to the family members after a tough diagnosis, things like that are going on. So, and then I also support our geriatric assessment clinic that we have there, both with you, Dr. Carr, as well as Dr. Binder. And in that role, I am doing psychometric evaluations with our patients and helping to screen for dementia, helping to provide community resources and the sort during those appointments. Those are a much, a full hour assessment where we're looking at every piece of everything related to health for the older adults. So memory and thinking and fall risk and all of the different things that go into older adult healthcare, as well as what is their social support, what is their financial situation like, what can they afford for support, what resources do they need to be connected to. So it's a really good holistic evaluation that we do during that assessment. And it's also a good complement to what's provided in primary care. So oftentimes if it's maybe something a little more complex than can be dealt with during a primary care appointment, we may get referrals over to us to look a little more in depth at what's going on and connect them with more resources and more supports. And overall, it's been a great opportunity to support many patients. I love working with all of the doctors that I work with and with Lacretia, and we have some wonderful medical assistants at our clinic as well. And like everyone else has said, it's just a great team. And I think we do a good job of meeting a lot of needs in a kind of a one-stop shop. And I also want to just mention that Covenant Place has a great team of social support staff as well, social work staff, and we work collaboratively with them oftentimes for the folks who live at Covenant Place who need ongoing support. So I'll be in communication with their social service staff and making sure that all of the services that are needed are provided to those folks.
Megan, thank you. I know I can speak for everybody and providers and for both geriatric assessment and primary care. We really appreciate your incredible experience and resources you bring to the table. And I know just on Friday in clinic, when is Megan coming back? When can I expect a call from her? And it was, you know, what can I say? You're an integral part of the team. So we really, really appreciate that. Now, before I come back to Joan, I don't know if Nikki's muted right now, but Nikki, if you're on, I know, great, unmute, that's super. I just want to introduce folks to Nikki, our practice manager, and again, just lots of accolades and appreciation for all her skills and assistance. Nikki, anything that you might say in particular regarding any insurance issues or logistics for patients and individuals, family members that are looking at switching over to primary care at our clinic?
Yeah, absolutely. So we take most of the plans offered to seniors. The primary one that seems to be the biggest frustration and that we wish we could contract with, but it's not going to happen anytime soon, is Essence, unfortunately. So our specialists do take Essence, so that's great. However, our primary care patients, we cannot see patients with Essence. If anybody would like to send a loved one their way, they are more than welcome to reach out to me or give me a phone number or give me a call. Sorry, doing too many things at once here. My phone number, if anyone would like to take that down, is 314-273-4376. And I'm more than happy to walk you through the process and getting established and checking if we're able to accept your loved one or you yourself if you want to be seen here. We have a really attentive, high quality team in this clinic, and we'd be more than happy to help you guys.
Yeah, Cam and Atasia and Margot, our MAs, are just amazing. And hats off to Nikki for her ability to recruit and bring really caring individuals as part of the team. As Dr. Holden mentioned earlier, it's there's many spokes in the wheel of providing care, and having that staff to answer calls, front desk, and help with the labs and the medication prescribing. It's truly takes a village, as they say. So Nikki, thank you. Anything else that you would add or want to pass on to the group here?
Not at this moment. If you guys have any questions, please put them in the chat and I'm more than happy to help you. All
right. Nikki, thanks. Thanks so much. So Joan, I thought if you had a few minutes, maybe talk a little bit more about the Mirowitz Center and what goes on there. I know with the pandemic, a lot of activities, as they have all across the country, have had to slow down. But Yeah, just talk a little bit about the different programmings and services and things, just sort of give people a little bit of a bird's eye view of what's there.
Thank you. Well, one of the things that we haven't talked at all about that I think is so important about this relationship is the health education that all of you provide through the Mirowitz Center. Megan ran a fabulous, when we were meeting live, program called Circle Talk, and it was come as strangers and leave as friends, and it was a curriculum over several weeks, and I have to say it actually worked, that people came as strangers and then ended up being very close friends, and that was terrific because that was just before all isolation set in, and I know that those people stayed in touch with each other through this past year. And there have been so many wonderful health programs, first in person when we were able to do that, and then all through the last year, many health education programs were offered on Zoom, including things about the vaccination and other areas of interest and concern. So the health education has been very good and very well attended. So thank you all for taking your time to provide that. The Mirowitz Center, the concept is pretty much everything under one roof that a senior might need or want. And so there's a cafe, and there's always the $5 senior special, so it's very affordable for people. There's all kinds of programming, exercise programs, everything is affordable or free. 8 exercise programs a week people can participate in, and these programs are run by professionals who work with older adults. So they're both chair and standing exercise programs. There's all kinds of things of interest. So a way for people to explore something that maybe they didn't have time to look at or to do when they were working. We have a community choir, and that was, we've learned that a lot of people, apparently their music teachers told them they couldn't sing. It was something they always wanted to do. So we have many people from that throughout the community who come to sing or to learn how to bake bread or we have Coca comes in and does art classes and speakers and all different topics, entertainment. And then also, in addition to the Washington University Geriatric Primary Care Clinic, there's physical occupational speech therapy, audiology. We have some nonprofits that hub with us. One is ITN Gateway Transportation, which provides transportation services for older adults. One is the St. Louis NORC, which has home services for older adults in the area. And we have a bank that comes in. So, if you need to get change for the laundry or to cash your check, your Social Security or whatever, you can do that and get some funds there very easily to access. And so it really is a holistic model. When COVID hit, like many places, we had to quickly pivot. We started the meals that people were coming to get. We did curbside pickup, or we delivered to our residents' apartments if they lived here. We started putting all our programs on Zoom. And we also immediately started a program because we had a feeling that wasn't going to just be a few minutes, this COVID. And we started a program called Tech Tutor, and we recruited volunteers. And we used to do this in an in-person program, so we recreated the tutoring to be over the telephone, pairing up volunteer tutors who had the same type of technology as the senior learners. So if you had an Android device or an Apple device, etc., you were paired appropriately. We have trained about now 500 older adults how to use technology, and part of that was in order to get them to be able to use Zoom. That was critical so that they could attend programs. Over the past year, we've had probably 6 to 8 programs a week on Zoom, and we have provided Zoom programming to over 7,000 senior adults. So that really took off, and I think one of the benefits, and we talked about this a little bit with the healthcare as well, is that it afforded opportunities for people who maybe wouldn't be able to drive to the center to participate in those programs, as well as for speakers from around the world who have been able to give their talks through the Mirowitz Center. We also started some support groups during COVID because we realized that the reason we were bringing everybody together in the center, a big goal was to decrease isolation. And of course, COVID just exacerbated the isolation. And so we set up several groups. One is with Dr. Kathy Cush from the Goldstein School of Nursing, Barnes Jewish, doing an owner's guide to aging. So talking about the issues of aging, the physical issues of aging. We did another one. We have a MSW who's doing a What's on Your Mind. We have a grandparenting group. And these groups have really been important to people who are really struggling, I think, through COVID, to have a place to come, know the other people in the room, and to carry on, these conversations and how they're doing and have that support and feedback. So we've tried to hit the same kind of programmatic buckets in this environment. And as we move forward, we will be looking to probably have a duality of programming, because the Zoom programming has really been important to many people who would not be able to access things in person. And we also know that the technology training is very important as we see more and more healthcare appointments being able to be facilitated through technology as well as in person. So we want to help train senior adults how to use the technology comfortably so that they can access those medical appointments virtually if needed.
Joan, thank you. I think it's pretty breathtaking when you think about all the activity that's come into the Merowitz Center, and granted the pandemic has kind of blunted a little bit of the things that are going on, but it just sounds just such a variety of different activities. And speaking of singing, I hear you have a wonderful voice. Is that something you could share with us now, or?
No, but at another time perhaps.
All
But
right.
I should say, before I forget, that we record most of our programs at the Merowitz Center, and they can be accessed at merowitzcenter.org under the News and Resources tab. So there's lots of these wonderful health seminars. All the people you're looking at on the screen pretty much have been involved in those, as well as a whole host of other programs. I mean, including like Father Dominic from PBS doing, baking for the holidays. So it's a wide range of programming. But so please, access that, share it with others. If you want to get on the Merowitz Center email list, you can email me or just go to Merowitz Center, and we send a weekly e-blast with upcoming programs. They're all free, all the Zoom programs. So if you have older adults in your life, or you may enjoy some of them as well, please access them. We love to share. And I do want to say before this ends, is I do want to say thank you also to the Friedman Center and the Foundation for the honor. It was very humbling to be honored with this recognition, and it really means a lot to me and to our whole board and community. So thank you.
Well deserved. Well deserved. So I'm going to jump around a little bit now. We have some hot chat questions that just came in, and I'm going to pop these over to Megan, if she'd be so kind. And one person asked specifically, what do we do for the adult caregivers? Any specifics you can give? And do you see any sort of gaps in the care that either the caregivers or the patient are typically saying, I wish I had A, or I wish I had B, and where do you get that?
Yeah, so I think one of the unique things about our clinic that you don't see in a lot of other healthcare locations is that we encourage our patients to have their family member come with them to the appointments and be a part of that, so that they understand what's going on with their loved one's health and what the needs are. I know I've been trying to convince my own grandmother to come get care there, because I'll talk to her on the phone and she say, well, my doctor says I'm doing just fine, and nobody knows what's going on with her health. So, it's just that opportunity for the family member to be involved in the care as much as they can. We of course will, make sure the patient is comfortable having their family member there. But then with our geriatric assessment clinic, we require that either a family member or a close friend, somebody who knows the person well, be involved in that evaluation, so that we have good collateral information on how the person is doing at home. So we value the input of that family member and or friend in assessing the person's overall health and well-being. And then when we discuss the issues that are going on, we make sure that the family member has the resources that they need to be able to provide support outside of our clinics. So making sure that they know who to call for home care services, or to get Medicaid set up, or to get a private care manager that can help to oversee their loved one's care if they're maybe not local, or they're busy working all the time, or whatever the barrier that they may have to providing that support. We make sure that we get them the resources they need to help break down some of those barriers. As far as what the needs are, I think I addressed a couple of those, but oftentimes it's just that it's you know, my mom is fiercely independent and she wants to stay at home by herself. She doesn't want anybody in the home. So it's okay, how can we break this down in a way that we can communicate to her the importance of it, and how bringing somebody into the home is a way to keep her independent as opposed to take away independence. So it's a lot of that education with the family on how to communicate these things to the patient or with the patient, and to approach these caregiving issues in a way that will make it easier for them to accomplish all of our overall goal, which is to help the person to live their best life as they age. So I think did that answer your question?
Yeah, hopefully it did. I think that was excellent. I appreciate it, Megan. A question came in from Dr. Carpenter about any research efforts to look at efficacy now that the clinic is more mature. And that's a great question. I think a couple of things, Brian, in response to that, and the answer is no. Part of it is we're still a pretty small footprint, although we think our care is mighty. And Nikki actually just checked in about 10 minutes ago saying, you know, we've got about 600 patients we're caring for right now in the primary care area, and that'll probably expand by another couple hundred. But, part of that is, providers are 0.5 FTE half time, and part of that is space limitations, and part of it is just the reality of patients having to come back periodically and during the given year to be seen because of frailty and complexity. Having said that, there have been some efforts, small efforts on our end in looking at Brown with some faculty and looking at some of our own efforts to try to look at some of those outcomes. We are required through the Missouri Foundation for Health to, report on our, hospitalization rates and emergency room visits and geriatric assessment. But it'd be very hard to compare us to other programs. We're small enough that we would really need to partner, I think, with other sort of similar type practices that are embedded within sort of wellness centers. And to that end, Joan and I had met with a group from out east that have started to look at this. And we do hope as our clinic continues to mature over the next year that we can partner with other faculty here, like Brian, and other groups and other clinics, I think, to have a reasonable size enough from that standpoint to really look at efficacy and things along those lines. I don't know if anybody else has any from the panel comments regarding that. Still kind of moving through the group. Lacretia, I was kind of hoping you might comment a little bit on the nurse practitioner's role and how that has been in the clinic and how that may or may not differ with some of your nursing background and clinical experience as a nurse practitioner. How have things gone from your perspective as far as providing care and any barriers to providing care that you see?
It's going pretty well. I work as a fully functioning provider, and I'm here 5 days a week as opposed to my cohorts. And so I do a lot of coverage on the back end for them, as well as seeing my own follow-up patients. Usually I don't see initial consults or initial evaluations to establish care in our clinic, but we do try to make it a rotation where I see them every other visit in order to make space for more new patients to come into the clinic. I'm also here every day as a person who can be seen for urgent and more acute visits. I answer a lot of my chart messages and phone calls. So if you don't hear from Tam or Kaori, it's because I've already got it covered.
Makes sense. All right, thank you. Another question that came in was about age criteria. Dr. Burge asked that, and I think I have this right, that generally we shoot for age 60 or greater, do accept both Medicare and Medicaid. Although Dr. Holden and I just had that discussion today, there are, as you might imagine, a fair number of adult children who are interested in also being part of the clinic. And so, we're putting it on the old agenda, and we'll discuss about potentially, lowering that option. I think we all understand that obviously providing care to a family is a pretty neat concept, and being able to do that. And of course, some of our adult children aren't necessarily spring chickens themselves, and have health issues that may be appropriate for the skill set of all involved. So I think more to that, but right now it's 60 or greater.
This is also because they love you. I'd love to share. We have a resident, he's in his mid-80s, and he's kind of a difficult guy. And he went to his first appointment with Dr. Holden, and I happened to see him. He was walking by me, he grabbed my arm, and he said, "I just have to tell you, I just had the best doctor appointment of my life." And it was amazing, because this is not a person who's normally happy or excited. So kudos to you.
I hear you. Great. Thanks for the feedback. So Dr. Sakurai, one of these sort of concepts that you've led the charge in the clinic is being part of the age-friendly systems. And I'm not sure everybody, but I'm not sure everybody who's kind of signed in on the lecture knows about age-friendly and specifically some of our efforts that we're doing to sort of deserve the title, if you will. So if you wouldn't mind talking a little bit about that, that would be great.
Absolutely. So age-friendly health systems, it's actually an initiative, a joint initiative of the John A. Hartford Foundation and also the Institutes for Healthcare Improvement. And we've actually been recognized first as a participant and now actually as an active health system, an active age-friendly health system. And what we really emphasize is providing evidence-based, high-quality care. And we all like acronyms and ways to remember things. So in geriatrics, we use something called the 4 M's. And what we're emphasizing in terms of our patient care is, first of all, and most importantly, is what matters most to our patients. So we go over goals of care, care preferences across care settings, different, whether it's the hospital or whether it's outpatient settings, as well as looking at advanced care directives. So that would be the what matters most part. We look at mobility, so physical functioning of our patients, safety, avoiding falls. We also emphasize mentation. So looking not only in terms of mood, so depression, anxiety, psychiatric disorders, but also cognition. So delirium and dementia and how it's affecting our patients. And then finally, we also look at, we're looking not only at those three, but also medications. So we all know that polypharmacy is unfortunately a big issue, especially in our elderly population. So we are actively looking at medications, making sure that the patients are on the right medications, looking at medication-medication interactions, looking at medication and chronic disease interactions, and really trying to help educate our patients and our patients' caregivers in terms of what's most important to the patients.
Dr. Sakurai, thank you for that. And we really appreciate you taking the time and the effort to get into age-friendly and help guide our system. A lot of components were there, but putting it together and being able to just provide some excellent comprehensive care, I think is great. We got time for maybe one last little one I'll put to Dr. Holden, and that is, there are great primary care doctors in the community, and we know we go to them, and they provide very excellent care to geriatric patients, older adults, and even many with complexity. But what might you say to a family or a patient that might be sort of the added value for our clinic? What is it that we may be able to offer that they might consider coming to the clinic? And we're facing, seems like every month I'm seeing patients that are telling me their primary care doc's retired, and they're looking for new patients. And unfortunately, I think we have more people retiring than we have coming into the field, probably from primary care perspective. But yeah, any closing thoughts on that you might pass on to family or the patient?
Yeah, that's sort of a loaded question, and I would refer to the last 50-minute discussion of what we have to offer. But in a nutshell, I think there's a couple things. One is we have a luxury of time, and I think Dr. Sakurai said it really well, that when people come with lots of competing medical problems, very complex care, 15 minutes doesn't cut it. And I always, I agree, there's great doctors out in the community. And I always say that there's not this magic elixir that a geriatrician has that an internist doesn't, per se. But we have sort of a familiarity with complexity. And I think this idea, like Joan's example of the person with the 2 pages of business cards, I remember that patient very, very well. Geriatricians sort of love to simplify things. I've sort of realized we love complexity. That's what draws us to the field. And I think that's where we can help a lot, but we also love to simplify. We love to simplify complex, medicine regimens. We love to simplify the care when you're seeing, too many specialists. And why am I seeing this sort of heart doctor? My heart attack was 10 years ago. And I think we take that sort of whole big, messy sort of overview of their healthcare, and we try to simplify things. And I think we're pretty good at it. Number 2, I sort of mentioned that the luxury of time. Number 3, teamwork, for sure. Having the resources and the team to help people, because with a lot of sort of these geriatric syndromes or things that are more prevalent in older adults, there's not a quick fix. There's not an easy cause of some of the problems, and there's not a simple solution. And I tell people you have to sort of attack these problems in a lot of different ways. And oftentimes it's not just medicines, obviously. And if you do a lot of little interventions, it can really add up to a very meaningful clinical impact. And so to sort of enact all of those little things takes time. It takes a relationship with the patient, the caregiver, the community resources, our team. And we sort of go on this journey together. And that's what I love about primary care, is we're on the journey with them. And let's be honest, it's to their end of their life. That's sort of the plan. For a lot of our patients, that's 30, 40 years from now. Some, it's more proximate, it's coming up, and we're with them throughout that journey, sort of whatever that timeline is.
Wow, that sounds great. Tim, thank you so much. And I want to thank the members of our panel. I think we've kind of come down to the end here. We've been keeping track of the chat area, and I believe we've addressed, I've certainly apologized to any members of the audience if we haven't covered it all, but I think we're there. And Nancy, any concluding comments? I want to thank Dr. Holden, Sakurai, Ms. Daniels, Ms. Herman, Ms. Denison, for spending their noon hour with us here on Monday. And it's been a great team to be affiliated.